Okay, I think we can begin. And as usual, in this meeting since the very beginning, we will have a welcome address from the local. Robert Gill, member of the club since a very long time. I even don't remember the first time. So you have 15 minutes. We are waiting for you.
Yeah, thank you very much. I appreciate this invitation. This is a big honor to do that. Just to start, I have no any conflict of interest in this presentation. So I'm not originally from Warsaw, but I fall in love with this in this country, in this city. Where is the point? Where is the point? I don't have an. Okay, thank you very much. So, this is Poland. Poland in Europe. This is fifth country in Europe, in fourth right now, after excess of Great Britain in terms of area and population. You see here almost 38 million of people. We are centrally located centrally in Europe. So the country is divided into 16 voivodeships, kind of districts with small capitals. The main capital is Warsaw, located, let's say, on the two sides of Vistula River. Here you can some information about the city. The Warsaw was established as a capital in 1592, just after Krakow. This is our second, basically, capital, because the first was Gniezno. Doesn't matter of the history. The metropolis, as you see here, stands on River Vistula in this east central part of Poland. The population is around 2 million people. This is a very big area around this part of Vistula. You can appreciate here that the city or area is divided into 18 districts. The area covers by all of these districts is more than 6,000 square kilometers. So Warsaw today is a big European city. You can here appreciate the skyscrapers of Warsaw. This is a downtown of Warsaw. It looks very nice, but the history of this city during last 80 years is different. So just before the Second World War, that was a diamond of the Europe, I would say, in terms of architecture and nature. It was called Paris of the North. You can appreciate here the architecture, which was very similar to Paris, really. We were very proud of this city for years. That was a beautiful piece of architecture. We love this city. That was the capital of Poland. On the last picture, you see the first skyscraper of Warsaw. That was, you can appreciate here. And then here, a part of old history, a so-called palace on island, located in central parts of Warsaw, by the way. In terms of communication, you can appreciate here that that's before the Second World War, it was well prepared. Let's say the life in Warsaw was very convenient, very comfortable. I would say, and the population of the city was 1,300,000 people, a huge city in that time. However, the 1st of September 1939, not right now. Just the symbols of Polish statehood. This is a royal palace. This is a parliament just before the Second World War. That was a presidential palace. And here you can appreciate the palace of Saski Palace with the location of headquarters of Polish army mainly. So the 1st of September, the aggression of Nazi Germany. And here you can appreciate the bombing of Warsaw. This is a royal palace. This is the parliament. This is just a picture showing how the city was attacked after 22 years of fighting. There was a capitulation of the Warsaw. In 20% of architecture was completely destroyed. But that was then not the end of the war story in Warsaw. Here you can appreciate that 1st of August 1944 there was a Warsaw uprising. For years it was hidden by, let's say, for Western people. There was only story about the Jewish uprising in 1943. But the second one was Warsaw was not very, let's say, pleased and stable a city for German Nazi. That was the truth. Here you can see the troops of Polish soldiers, civilian soldiers, and fighting. And even with some successes, we took prisoners, war prisoners. From Germany, but finally at the end of September, there was a capitulation, and that was a time when Hitler was just after the assassination attempt in July 1944. He was got mad. He was very badly attitude to the situation in Warsaw, because it destroyed her plans to defend Soviet troops. And here you can appreciate the consequences of this uprising. That was Warsaw. You see here at the end of the picture this first skyscraper of Poland. Look, this is the old town. This is also the central part of the Warsaw. It was completely destroyed. We lost 700,000 people. We lost more than 80% of architecture. But we rebuilt everything. Here you can appreciate Royal Palace, residential castle. This is Parliament. This is City Hall of Warsaw, and then the residuals of Saski Palace with the tomb of unknown soldier. Today, everything looks very nice. This is a palace on water. This is Villanov Palace. This is similar to Paris Palace, Versailles, and then that was one of the reason why it was called Warsaw as a Paris of the North. This is a great theater. This is part of Old Town, the same, and this is a very well known for tourists, a New World street. Look at the location of the new buildings, the beautiful pictures of Warsaw. The life here is really very good. This is very well infrastructured city in the central part of the world, of Poland, and then you can appreciate this special illuminated piece of architecture. This is a gift of Stalin. The seventh of the same buildings is in Moscow. The eighth is in Warsaw. That was a great debate whether it should be destroyed or not. Finally, that it was decided to keep it, to remember who was the real enemy. Some words about the Polish interventional cardiology. In 2016, we had 159 centers located very well, distributed equally in Poland, in these 16 voivodeships. But right now, it looks like that. We have almost 170 centers in 2023, with the members of Association of Interventional Cardiology, Cardiovascular Interventions of Polish Cardiac Society, more than 1,200. Here you can appreciate the increasing numbers of procedures for acute coronary syndrome and association between the decreasing of mortality of this patient. This is our work. The position in Europe in 2010 was not so bad. We were in the first 3 leaders of the intervention of primary PCI for acute coronary syndrome. Here you can appreciate the highest number, that was more than 700 per million. But of course, during last years, we observed the decreasing. It is also a result of prevention taken in our country, and of course, due to the COVID-19 pandemic, we observe 25% decrease of procedures regarding diagnostics and intervention procedures as well. We are also busy with structural heart diseases. Right now we have at least half of the average procedures for TAVI. We are also busy with pulmonary valve treatment, the mitral edge-to-edge procedures. Not so bad as well. However, we have to improve it. For tricuspid, we started right now, but it's increasing. But we have also some new devices in terms of structural heart disease. So thank you for your attention.
Thank you for this piece of history. I think it was a good idea to keep this thorough, from my opinion, because this is to remember. So this is part of your history, and it was, but it also was beautifully rebuilt and a very beautiful city. So thank you for this presentation. So now, you can come here. There is a place. No, you need an additional chair. Is possible? Okay, so first of all, I want to present you Dr. Shigeru Saïto. He's an old and good friend. We were in the campaign of, can call it a campaign, it's not a war, but it was a campaign of radial approach. For many years, we were proposing the radial approach everywhere in the world with Jean Fajadet, with Ferdinand Chiamenet, and Shigeru, myself, and many others. So I'm very happy to see him. He wanted to visit this meeting. I'm very happy to see him with us. So please, Shigeru, please call the first speaker.
Okay, I'm very pleased to introduce the first speaker from South Korea, Dr. Kang. He will present the antiplatelet therapy in ACS patients and bifurcation lesions? Please, thank you.
Yes, thank you for the kind introduction, and it's my honor to have a speak at the EBC 2023 with the opening of the second day. As you can see, my talk will be antiplatelet therapy for ACS patients with bifurcation lesions, and I will divide this into the acute phase and the chronic phase for antiplatelet therapy. Now, regarding the guidelines of antiplatelet therapy, we know that there has been various clinical trials that have evaluated various strategies of antiplatelet therapy. And now we have a very complicated guideline, and to make it simple, the DAPT duration or intensity is stratified by the clinical presentation, which is stable coronary disease or ACS, and if the patient has any kind of high bleeding risk or not. So in this kinds of era, how should we use DAPT in ACS plus bifurcation PCI or complex PCI? And what should we consider in determining the intensity of DAPT? So there has been a couple of studies that have evaluated the DAPT duration in complex PCI, and this was the first study that gave us the concept of complex PCI. We can see that bifurcation with two-stenting technique was included in the definition, and this study evaluated that a longer DAPT, a DAPT more than 12 months, significantly reduced the ischemic outcome compared to those who had a shorter DAPT duration. So this gave us an insight that the procedural complexity should be considered when we determine the DAPT duration. However, a following study then showed that not only the complex PCI, but the high bleeding risk, the patient characteristics are also important, and only if there is an absence of the HBR that a longer DAPT is better when we perform longer DAPT for complex PCI, which includes bifurcation to stenting techniques. So again, we have to consider the procedural characteristics and the clinical characteristics when we determine the adequate DAPT duration for a patient. So then how should we treat these highly thrombotic patients who present as ACS and have a bifurcation PCI? We can divide this into the acute phase, which can be defined as within the first year after PCI, and the chronic phase, which can be defined as after the first year of PCI. So we can consider the thrombotic risk, the bleeding risk, and there are various kinds of strategies that we can consider in these kinds of patients, and I will talk about this in the following slides. So to simplify the contents of my presentation, I would like to divide this into antiplatelet therapy in the acute phase and two topics, whether we can abbreviate antiplatelet therapy or can we soften the DAPT intensity. And then beyond 1 year, is there a specific antiplatelet agent that should be prescribed? So regarding the first topic, can we abbreviate antiplatelet therapy agents? When we consider the DAPT duration, as I said, there are various factors that we should consider, the patient factors, the angiographic or procedure factors. And if we want to abbreviate or kind of tailor these kinds of antiplatelet therapy agents, we should consider how long these patient or procedural factors give any impact into the outcome of the patients. So to compare the clinical and the procedural characteristics, we did analysis of the Grand DS registry, which is a registry that we have in Korea, including more than 13,000 patients. And all the patients were divided into clinical characteristics and procedural characteristics. And in this slide, we can see that there was a substantial amount of patients who had bifurcation lesions, which was a procedural characteristics. So during the 3-year follow-up of this patient, we divided the patients into high, intermediate, low clinical risk patients and high, intermediate, low procedure risk patients. And we did an annual landmark analysis. And in this slide, we can see that during the first year, both the clinical and the procedural characteristics were important. However, after the first year, the procedural characteristics, the importance declined, which made the clinical characteristics the more important factor. So we can consider that at least during the first year, the procedural characteristics are very important in the clinical outcome of the patients. So we should keep in mind the procedural characteristics, that is, if the patient has received bifurcation PCI, in determining the DAPT duration of the patient. So based on this slide, I can say that it might be slightly risky to reduce the DAPT duration because the procedural characteristics have a large impact during the first year after PCI. So then the second topic, can we soften antiplatelet agents? There are a lot of strategies to de-intensify the antiplatelet strategies that we do, especially in ACS patients. And we did a study called the Host-Reduced Polytic ACS trial, which was a clinical trial to determine whether we can de-escalate a potent P2Y12 inhibitor while using DAPT during the first year after ACS patients. So as you can see in the figure right here, we evaluated the de-escalation group, which was a aspirin, prasugrel therapy, and within the first month, the conventional dose was used, and after the first month, prasugrel was reduced to a half dose. So overall, in this trial, we could see that overall in ACS patients, the de-escalation strategy had a risk reduction about 30%. Then can we apply this kind of strategy to those who have a complex PCI, who receive bifurcation PCI? So there was a sub-study that we did of this study, and we could see that there was about 1/3 of patients who had complex PCI within the total patient population. So before doing the comparison between de-escalation strategy and conventional dose strategy, we could see that from this slide that complex PCI itself did have a large impact on the ischemic outcome, MACE, during the first year after PCI, while the bleeding events were quite similar, which is quite easy to understand. Also, many of the factors that are included in complex PCI, that includes 3-vessel disease, more than 3 stents, etc., all had a small and impact in increasing the MACE rates, which means that all of these factors have additive value in increasing the ischemic outcome of complex PCI patients. So then in the complex PCI patients, when we compare conventional DAPT and the softer de-escalated DAPT, we could see that by performing a de-escalation, this means that using a half dose of prasugrel while using dual antiplatelet therapies within the first year, had a decrease in NACE, which was majorly determined by a decrease in the bleeding risk. However, there was no trade-off of increase in the ischemic risk. So by this slide, we can see that even in those who have a complex PCI, which includes bifurcation PCI, we can de-escalate the potent P2Y12 inhibitor, even though if this patient has presented as a ACS, which means that we need a potent P2Y12 inhibitor during the first year. So then going to the third issue, is there a specific antiplatelet agent that should be prescribed? Well, this was based on the HOST-EXAM trial, which was another trial that we did, which compared clopidogrel monotherapy versus aspirin monotherapy after the first year of PCI, which excluded those with any kind of clinical events. This means that these patients were stable CAD patients who received PCI at least 1 year ago. So of this study, some of you might be familiar with the results, but we could see that clopidogrel monotherapy as compared to aspirin monotherapy decreased the clinical outcomes of up to 27% with a risk reduction of 2% within 2 years after follow-up. I would like to stress again that these patients were not enrolled during the index PCI period, but they were enrolled after they were event-free of the first year after PCI. So again, can this strategy be applied to those who have a complex PCI, a bifurcation PCI patient? So we should talk about the thrombotic risk if we want to discuss of the complex PCI. So again, we did a sub-analysis of this study, which included the high thrombotic risk patients among the patients that were enrolled in the HOST-EXAM trial. Again, we can see that there was a large amount of patients who received various kinds of complex PCI characteristics, and we can see that there were some patients who received a bifurcation two-stenting techniques. So before comparing aspirin versus clopidogrel, is complex PCI a risk factor after the patient is stabilized during the first year? Surprisingly, in this slide, we can see that after the patient is stabilized, complex PCI itself was not a risk factor of any kind of adverse clinical events during after the first year of index PCI. And also on the right panel, we can see that the number of complex PCI features was not associated with an increased risk of any kind of clinical event. We can think that a larger number of risk factors of complex PCI might give us a higher thrombotic risk, but this was not present after the patient was stabilized during the first year. So then in the complex and non-complex PCI patients, we compared aspirin versus clopidogrel, and we could see that although the P4 interaction in the right, it was 0.181, which is insignificant. However, we could see that the impact size of clopidogrel risk reduction was larger in that of in complex PCI patients. In complex PCI patients, the hazard ratio was 0.61 compared to 0.80 in non-complex PCI patients. This was there was no significant interaction, but still we can say that probably the risk reduction in complex PCI patients might be larger when we prescribe clopidogrel instead of aspirin, which is in the current guideline right now. And in the X panel, we can see that this was a long-term follow-up which extended up to 5 years, which means that it was 6 years after the index PCI period. So during this long-term follow-up period, we can say that as compared to aspirin monotherapy, clopidogrel monotherapy was superior even in those who received any kind of complex PCI patient. So this is the conclusion and the last slide of my presentation. Patients who present with ACS and bifurcation lesions obviously have a highly thrombotic risk, and potent P2Y12 inhibitors and aspirin is recommended because these patients are ACS patients, not because they have received bifurcation lesions. And within the acute phase, because the procedural factors have a impact during the first year, the APT should be maintained. However, it may be softened, such as a dose reduction of the potent P2Y12 inhibitor. In the chronic phase, which means that after these patients are stabilized, clopidogrel monotherapy may be superior as compared to aspirin monotherapy, especially in complex PCI patients. Highly thrombotic patients, ACS plus bifurcation PCI patients, can use prasugrel-based de-escalation followed by single antiplatelet therapy of clopidogrel, and this may be a feasible option. And thank you for your attention.
Dr. Kang, thank you very much for your very comprehensive, summary of antiplatelet therapy. So, anybody, you?
Question or
Yes. Good morning.
question or comment?
I have a question. So, congratulations, really beautiful data. Can you comment on the use of imaging in the both studies?
Yes, this is a very important comment. Well, actually, both studies were performed 100% in Korea. So the imaging usage was about 30%, which is an average number that we have in Korea. It's slightly lower compared to the numbers in Japan, and slightly higher compared to the numbers in studies performed in the Western countries, but it was 30%.
So do you think that the high use of imaging also correlates to the results? Do you think that if the imaging wouldn't be used, the number of thrombotic events might be higher? So if we have high bleeding risk patients and plan to reduce to short the DAB, should the imaging be obligatory?
Yes, of course. I think that imaging is a very nice tool to reduce any kind of clinical event. Well, actually, this is especially in the first year because most of these thrombotic events occur in the early phase after PCI. After the patient is stabilized, I'm not sure that imaging, which was performed 1 year ago, might have a clinical impact in the adverse outcomes.
Petr Kala is with us. Petr, comment or question?
Hello. So I think that the imaging is really crucial for the future, and we have now very good data from ESC, from the meta-analysis, and also from the original studies that were presented. So the risk of especially of thrombosis was really significantly lower. And it was more than 50% lower than in the control group. And so I think that also for the antiplatelet and thrombotic regime, this is quite important to take into account. And I would like to congratulate my colleague to their work and to their results, because this is a really very important clinical issue. And I don't have any question now. Thank you.
Thank you, Petr. Just a brief comment from me because we are late. So I'm thinking that why we are not putting this hemorrhagic potential inside the MACE rate. If you look, if you take the point of view of a patient, MACE is not enough to describe the events. You have to add the hemorrhagic problem. I think I don't understand why we have the thrombotic problem and we are not taking into account the hemorrhagic problem. So I think if we push the treatment with antiplatelet, antithrombotic treatment 2 years because you did very exotic techniques with a lot of metal, normally it has to be associated with some events, hemorrhagic events, and it has to be part of comparison of two strategies and two techniques. So this is my point of view. This can be discussed, but even in the club, we may decide to propose this. This is a question. So next presentation, please, Jolanta, call the...
So now it's my great pleasure to invite Dr. Kinoshita, who will be sharing with us his expert opinion on the importance of bifurcations in the CTO PCI. Dr. Kinoshita, welcome to the stage.
Good morning, Chairman and ladies and gentlemen. It's my honor to be here, and I'm glad to meet EBC members. This is not my slide.
This is not the good slides. So we can go on with the question. I was looking at Jacques. Jacques, what's your opinion about what I said just before? You have patients that may have more than 2 years, maybe more, even more antithrombotic treatment, and we are not including in MACE rate any of these hemorrhagic problems. So a microphone for...
I absolutely agree with you that it should be included. Hemorrhagic complications are sometimes more dangerous than just ischemic ones. So this is good comment, but also I would love to acknowledge the comment of Jolanta that the intravascular imaging is the tool which has to be used in those patients at high thrombotic risk, high bleeding risk, especially if we do complex PCI procedures, because this is the only way to lower the risk of stent thrombosis. And then
we will discuss this afternoon. So this, please, Dr. Kinoshita.
Okay. Thank you. So actually we have been challenging the treatment of the CTO for more than 30 years. Actually, we introduced EBS guidance and CT image guidance for the treatment of CTO from early days. And in 2006, Dr. Sumeri, he's a seat doctor, he reported the first original CAR technique in the world from our center. And in 2010, Dr. Latour, he's one of the EBC member, also reported on the reverse CAR technique from our center. And we've also involved in the development of the collagen microcassette and Gaia wire. 2 years ago, we reported the importance of the side branch protect in the treatment of the CTO bifurcation. So fortunately, this paper was cited in the list published the expert consensus document from the European Bifurcation Club and the EuroCTO Club. Today, I would like to talk about this our study. The purpose of this study is to investigate the appropriate strategy for the CTO bifurcation region. So totally the 314 patients out of the 1,049 patients who underwent the CTO PCI in 3 centers from the 2010 to the 2018. All of these 314 patients has a bifurcation involved in the CTO region. The side branch diameter is more than 2.5 millimeter. And we divided these patients into the 2 groups, and one is a side branch loss group, another is a non-side branch loss group. Side branch loss was defined as a final thrombolysis in TIMI flow is less than grade 3 in the side branch. So this is a flowchart of this study. The totally, so 1,049 we excluded from the 1,049 patients. We excluded the 141 unsuccessful case, and the 301 the cases without no follow-up, and there are 893 cases without which is no bifurcation CTO regions. So finally, the remaining 314 regions were divided into two groups. One is side branch loss group, number is 47, and another is a non-side branch loss group, number is 267. And so as a result, in terms of the patient case characteristics, so the side branch loss group had a higher percentage of the presence of stenosis in the side branch, and the side branch located within a occluded segment. But otherwise, there is no difference, no significant difference between the two groups. Together with procedure characteristics, the side branch loss group showed the more use of the RDR technique and the subintimal tracking at side branch ostium and the subintimal dissection. And also the carina and plaque shift after stenting in the main branch was significantly more frequently observed in the side branch loss group. So regarding the clinical outcomes, there is no difference in the MACE between the two groups, but the TLR in side branch, TLR for side branch is significantly higher in the side branch loss group. So regarding the predictor of the TLR, the side branch loss in RCA and subintimal tracking of the side branch os were significant, strong predictor, independent predictor. And this shows the Kaplan-Meier analysis of the cumulative 1-year instance of the TLR. Although the TLR in all regions, there is no difference between the two groups, but the TLR in RCA, we could see a significant difference between the two groups. Actually, the side branch loss group are significantly higher. And concerning the predictor of the side branch loss, the It's the multivariate analysis indicated the third branch located in the within the occluded segment, and the side intimal tracking at the side branch ostium, and presence of the side branch stenosis is a independent predictor in this analysis. And also, we performed the sub-analysis of 82 bifurcation lesions located within the occluded segment. This is about 25% of our subject, and it shows that the two-cent strategy is a little bit better than to keep the side to keep the good side branch outcome compared to the one-cent technique. So, ladies and gentlemen, this is my conclusion. The predictor of side branch loss were presence of side branch stenosis, subintimal tracking at side branch ostium, and the bifurcation lesion located within the occluded segment. Especially since suboptimal side branch result in RCA may lead to TAR on main branch, it is important to keep the wire inside plaque to preserve side branch. Use of two-stent strategy may be desirable for the preserved side branch patency in the treatment of the CTO bifurcation lesion located within the occluded segment. And this is my final slide. At about the same time of our report, there was a report from China that suboptimal side branch results are related to the prognosis. So I'm convinced that it is important to treat the CTO while the side branch, preserving side branch appropriately. Yeah. Thank you for your attention.
Thank you very much. Who has a comment or question?
Manuel on Dr. Oreda published on this.
Congratulations, Yoshi, for your data. No, my question is about the protection of the side branch with a wire. I didn't see that the possibility to protect the side branch is a factor of side branch loss. If you can't protect the side branch, do you think that this is a factor induced the possibility of side branch loss?
Yes, thank you for your question. Actually, in the CTO region, especially the side branch from that coming from the in the CTO region, it's difficult to keep the only using the protection wire. So sometimes we need the gel bond technique. And after putting the stent, and after that we often use recently we often use DCB to the side branch.
Yeah. Just a comment.
Yep.
Did you perform an analysis of the location of the side branch? In the top of the bifurcation, the middle, or at the end? I think there is a great difference in terms of side branch loss when we are in the CTO, just in the middle or at the end parts.
Yes, thank you for your comment.
Manuel was paper was also the present inside the corpus of the occlusion is a higher risk of losing the side branch, which is logical.
Yeah, actually, so of course, the side branch position is very, very important to if we can keep the side branch. But proximal side branch, side branch at the proximal of the CTO region, actually that is easy to keep it. But most of the difficulty is side branch from just within the CTO part.
Oh yeah, there's a question from Professor Kala. Yes, please. We can't hear you. You are probably mute.
Sorry. I would like to ask you, and thank you for the data. I would like to ask you about the selection of side branches that have to be protected. So are there any side branches that you are not interested? Of course, I'm not talking about the diameter of the side branch, but if we are talking about the side branch at least with diameter 2.5 millimeters, are there any of them that you are not interested in preserving them?
Thank you for your question. That actually, in this study, how can I say, simply to correct the data, we have a limitation to the side branch diameter is more than 2.5. But actually, recently, we always in almost all cases we check the CT angio, CT image before the CT lesion, and we always calculate the territory of the side branch. If the side branch diameter is less than 2.5, but this side branch territory is more than 10%, at that time we try to keep the side branch.
This is using the relevance of the side branch, the concept created by Bon-Kwon Koo. So yes, I understand. It's time to move to the. Thank you, Dr. Kinoshita.
Yep. So now it's my great pleasure to invite Professor Gil, who will be sharing with us data on the BiOSS LimC stand, a dedicated stand for bifurcation.
Thank you very much once more for inviting me. Somebody can be a little bit surprised that we are back with the history of BiOSS, but I have to announce you that COVID-19 pandemic and the death of owner of the company Balton changed completely the plans and transferred our dream somewhere outside. But anyway, we have 4 years follow-up of this stand, and I would like to show you that the data, just to remind you and ask you, not kill the idea of dedicated bifurcation stand. I'm truly believe that there is still place for that. Before I will go into the details of the results. Just to remind you, the stand, 2 pieces connected with 2 connectors, 70 micrometers struct thickness, biodegradable polymer with sirolimus in that. The mechanism of implantation, just to insert the stand in a proper position, giving a good access to side branch. The stand is located on a special balloon with a bigger sizes in proximal, say smaller for distal positions. This stand was quite well tested also in animal study. Here you can appreciate the comparison with Orsiro stand in terms of the angiographic results and histopathologic. There was a very good results comparable to this particular stand. We started in the beginning registries for this stand. Here you can appreciate the inclusion and exclusion criteria. Just to summarize and simplifying everything, we just took for treatment patients with the big promise of results for provisional T stenting, and of course we try to exclude acute coronary syndrome patients and the lack of informed consent of the patient. We included also left main cases. Here you can appreciate primary and secondary endpoints as regular, normal for such studies. Then in terms of proximal optimization technique, which become a kind of the must, we included also this part for protocol of the implantation, because we started without this requirement, believing that the difference in the size proximal to distal makes the same effect. Here you can appreciate the population of this first in man with this stent. Some characteristics: 2 subgroups, left main and non-left main, well distributed without significant differences. Here you can see important issues regarding the protocol of implantation. What is really very bad that the percentage of proximal optimization technique, despite we asked the implanters to do that, was significantly lower than for left main group. That was below 50%, as you see here. And here you can appreciate the results of first in man with this BiOSS LimC stent. The MACE in general below 10%, TLR say around 6%. That was a total, let's say total values. But if we split this data for left main and non-left main, for non-left main, that was around 3%. So we went after that. That is also OCT performed for the follow-up, showing that there was a very good adoption of the stent within the coronaries. So we predicted looking in vivo late lumen loss, as you can appreciate here. So we got definitely similar information. So the conclusion of this first in man with BiOSS LimC was that this is a promising stent. We should go for the randomized trial, and then we organized that. This was POLBOS free with all of the same inclusion and exclusion criteria. I would like to stress that in POLBOS free there was no left main cases. The implantation protocol as regular already with proximal optimization technique as well. Here you can see the study flow chart. Unfortunately, because of COVID-19 pandemic, we stopped enrollment. So we stopped this enrollment on 116 patients with BiOSS LimC and 114 with regular drug-eluting stents. You can appreciate here the list of these stents used, and of course, all of these patients were under our control. We followed them for next years, and of course, as usual, the primary endpoint was the complex, included cardiac death, myocardial infarction, target lesion revascularization at 12, and then as a secondary for up to 28 months, so it means for 4 years. So if you look at the baseline characteristics, you can see that slightly BiOSS group was just younger. There was a bigger percentage of prior revascularization compared to BiOSS group. The rest was well distributed without significant differences in terms of Medina classification. The percentage of true bifurcation was around 70%. Some procedural details, and again, unfortunately, the percentage of proximal optimization technique was really very low. Just 1/4 of the cases, half for regular drug-eluting stents. Just to tell the truth, that was a trial, which was organized in 2 centers, in 2 post centers. So we were very straightforward in terms of protocol details. However, as you see here, we didn't succeed. Anyway, the rest was very similar to other. And then results after 4 years, or every single year, you can appreciate that the percentage of MACEs increased by years. but the differences between regular drug-eluting stents and BiOSS LimC was not significant. Here you can appreciate much better looking at the cardiac death. There was no differences in myocardial infarction, no differences in target lesion revascularization. There was slightly better for regular drug-eluting stents, however, without significance, and the same because of this previous one, the composite endpoint was also without significance. And just let me conclude that experience so far with BiOSS LimC stent shows that its further development is able to fulfill the initial hopes that it will be better in the treatment of bifurcation lesion compared to classic drug-eluting stents. I really believe that we shouldn't kill this idea. We should pay much more attention for details and using the well confirmed and proven scientific data in terms of optimization of our results. Thank you very much for your attention.
So thank you very much, Professor Gill, for sharing this important data. Who wants to comment or ask questions? Yes, over there. The micro is coming.
Well, thank you.
Thank you. Okay, so thank you, Professor Gill, for the excellent presentation. So in your slides, that the numerically higher rate of TLR for the BiOSS stent, and have you ever analyzed the location of the TLR in terms of proximal, distal, and side branches?
We already checked that issue in previous registries, but for sure that was not a mid portion of the stent, not at all. There was almost equal distribution for proximal and distal position. What we should do much better is just not only proximal optimization technique, but also distal optimization technique. This is one issue. The second, the usage of intravascular visualization, allowing us to better preparation for stent implantation optimization, the final result. And the third, we truly believe that construction of this stent is optimal for non-left main bifurcation. However, we need more potent anti-proliferation, let's say, action. And as far as I know, the Bolton compound already achieved that.
Thank you.
Thank you, Robert. I think we have to move. Yes.
Very briefly, thank you very much for sharing this interesting data. I had always thought that one of the advantages of the BiOSS stent was the possibility of skipping the pot, because it was already created by the shape of the balloon. However, I've noticed that it's part of the protocol.
We believed for that at the beginning. So therefore, in our primary protocol, there was not a requirement of pot. However, we found that without intravascular optimization, the calcification and fibrotic tissue, due to the non-compliant balloon for stent delivering the stent, resulted in a non-optimal result. So therefore, right now, I would say that after inspection, without a lot of calcium and fibrotic tissue, sizing properly, it's theoretically possible. But you know, intravascular visualization is not 100% cases in my country.
Sir, if side branch requires stenting, how would you do that? Is there any particular strategy we follow, or will just nail at the osteoma of the side branch?
Can you repeat?
The side branch stenting is required after this BiOSS stent. If the side branch needs to be stented, how would we do that?
I didn't focus on this topic for this particular group of the patient, but from other registries, we have data showing that the need of second stent implantation is less compared to regular drug-eluting stents. However, in this randomized trial, we observed an opposite. So it means that the operator wanted to improve the results for BiOSS, implanting additional stent sometimes too early. But this is the true. We can, with the proper positioning of the BiOSS stent, we can, let's say, decrease the rate of side branch implantation for sure.
Thank you, Robert. So we will have some news during the next years. You are continuing with this, yeah? We'll see. So the next speaker will be Bon-Kwon Koo. Welcome. He will speaking original talk this year on sex differences in procedural characteristics and clinical outcomes among patients undergoing bifurcation PCI.
Thank you. Good morning, ladies and gentlemen. So women and men are different, but some may disagree. But at least for coronary artery disease, difference exists in terms of clinical risk profiles, vessel size, disease burden, characteristics, myocardial mass, stenosis hemodynamic relationship, etc. And this is the reason why in the flavor trial, even though same criteria of IVUS and FFR were applied to both men and women, PCI rate was different. Women resulted in less PCI than men despite the same criteria for IVUS and FFR. And this was translated into the difference in outcome. Women had a better outcome than men. When we focus on a bifurcation PCI, you will see that there has been several decent large number of studies, but the results are different and contradictory. Some are saying women are worse, and some are saying no difference. And these contradictory results should be interpreted under the context of different characteristics between men and women and among different studies. So this is a very complicated studies, but you can recognize that the difference exists in terms of baseline characteristics and angiographic characteristics and also procedural characteristics. So in summary, we now recognize that sex-based difference exists in terms of outcome. So we need a very comprehensive investment into the baseline and procedural characteristics and their prognostic impact. So that's the reason why we performed this study on the sex-based difference in patient level and lesion level characteristics and procedures and outcomes following bifurcation PCI. So this is data from the COBIS-3 registry, which is a Korean multi-center real-world registry data, including around 2,600 patients. And for this study, we excluded small vessel bifurcation PCI, and we did the QCA for all lesions and include only the vessels, main vessel 2.5 millimeter or more, and side branch 2.3 millimeter or more. So this is the results. Like all cross-sectional PCI studies for men and women, women are older, leaner, more hypertension, more diabetes, and less smoking, so that it's universal. But it's interesting to see that the real-world cross-sectional data of the lesion characteristics or angiographic characteristics between men and women. So women tend to have a less prevalence of multivessel disease like the previous studies, but bifurcation location, left main or not, LAD or not, it's exactly the same. And bifurcation classification, true bifurcation, Medina classification, it's exactly the same. And it is also interesting to see the procedure results. So we know very well that the women has a smaller vessel, so that the main branch vessel size, side branch vessel size, women has a smaller vessel size. But in terms of bifurcation angle and angiographic percent diameter stenosis in main branch, side branch, and after PCI, residual percent diameter stenosis in main vessel and side branch is exactly the same. So it's interesting phenomenon. And for the procedural characteristics in Korea, men and women underwent the similar degree of IBUS guidance. And it is interesting to see that in terms of bifurcation PCI technique, simple crossover, one stent side branch balloon, two stents technique, it's exactly the same. And also the number of stents per patients and main vessel stent length and discharge medication is all the same. So in summary, despite the differences in baseline characteristics, lesion characteristics are quite similar and procedures are quite similarly performed. So then the question is, what will happen in terms of outcome? So we analyzed the 5-year outcomes. The primary endpoint of this study was target lesion failure, which is exactly the same between women and men. And for the secondary outcomes, cardiac death, myocardial infarction, target lesion revascularization, exactly the same, so equal. And it is interesting to see that the subgroup analysis, so there was no difference with the most of the subgroup categories, but like the previous studies that the age, diabetes, there was an interaction. So this means that you should be careful when you are treating bifurcation lesion in young diabetic women rather than the other counterpart. But left main category, two stenting category, there was no difference. And this year's EBC, we are talking a lot about imaging. So we analyzed the data according to the imaging, intravascular imaging plus intravascular imaging negative. So no difference in terms of the target lesion failure. But the limitation of this study is that we analyze only the Korean patient so that we collaborate with our Italian colleague to analyze the Italian data using the RAIN registry, which is another very big real-world registry, around 3,000 patients. And this shows that the baseline characteristics, so like our previous Korean data, women older, more hypertension, more diabetes, more hyperlipidemia, and less smoking, but no difference in diagnosis, left main bifurcation, true bifurcation, and two-stent strategy, so that it's universal difference in baseline characteristics, but the lesion characteristics and procedural characteristics now both are similar. And when you see the results, it's exactly the same as the Korean COBIS registry in terms of TLR, myocardial infarction, stent thrombosis, and MACE. There was no difference between men and women. So in summary, ladies and gentlemen, we recognize that the women and men are different in terms of baseline lesion characteristics, plaque characteristics, and reference diameters, but if you treat them equally, the outcome will be all the same. Thank you very much for your kind attention.
Very well done in time, as usual. So some question maybe from women. In my mind, remember some trials showing that really everything is different, but we are the same, except in the size of the vessel.
I have just a small comment here, Gianluca.
Yeah.
We published around 2 years ago same work, basically, about the left main bifurcation, women and men, in 500 people. And we saw exactly the same result, except the rate of bleeding in women with double stent. Bleeding is twice the bleeding of the men, especially in not by age but by weight. So the only different thing is that the women, in particular small women, if you put two stents, they bleeding more.
Yeah, I think that's a great point. So that I didn't show you the data. It is interesting that you may expect this, but the women, in terms of femoral radial, women has less radial approach, and our data also show that the bleeding risk is also higher in women, and I thought that it may be due to the approach.
I mean bleeding in the long term. Not bleeding from the radial and femoral was similar men or women.
Isn't it related to the dosage of the drug? Because they are taking the same dosage as we take.
Maybe, but unfortunately we don't have detailed in terms of doses, but the number of drugs are always similar. But I agree that they may matter.
There's another question.
It's more a comment because the risk factors for coronary disease between men and women are very different. Women have more diabetes, are older, less smoking. They tend to have more diffuse disease and not focal disease. And as we only treat really focal disease, not really diffuse disease, then the treatment options for men and women are quite different.
Right. So that there are several, baseline characteristics which unfavorable to women may be the small vessel, small stent size. But we also know that when we analyze the plaque burden and plaque characteristics, despite the more favorable baseline characteristics, men tend to have a higher disease burden despite the similar angiographic characteristics. And also, men has more adverse characteristics. So there are several favors men, favors women, but in combination, if we treat them equally, my message is they will show the same outcome.
Thank you. So other comments on this?
I would like to also comment on the bleeding risk in women and men. I think, as you have shown, that women are older and are sicker. So if we will use any of the bleeding risk score, I started to use the HBR Academic Research Consortium score because it's really easy to use. There's a mobile app. And I really started to use that for each PCI before the PCI, actually, because it changed very often my strategy. But if we use it in each patient, so 42% of all female patients undergoing PCI are on high bleeding risk, whereas 33 men. So actually, in more women than men, we should short or de-escalate probably. And also in your data, you have shown that, and that's the question, that less women received statins after the PCI than men. So what could be the reason for that?
I don't know the reason. This is the data, but I agree that we should, focus more on those, differences in terms of risk profile, patient risk and lesion risk, so that that may, the outcome, greater, more to the equal.
Right. Thank you.
Thank you.
Kwon. So please, Shigeru, can you present the next speaker, Japanese?
Okay, I'm very pleased to invite Dr. Fujimura. He will talk about the serial changes of the side branch ostial area after single crossover stenting with kissing balloon inflation. Okay, it's virtual. Oh, okay.
Easier.
Please. I cannot hear you. Excuse me, I cannot hear you.
EBC meeting today.
Yes,
I am Tatsuhiro Fujimura from Yamaguchi University Medical Hospital, working as a Japanese interventionalist for 20 years. Time is limited. I will start my presentation. The title of my presentation is Serial Changes of the Side Branch Ostial Area After Single Crossover Stenting with Kissing Balloon Inflation. In previous report, Dr. Okamura defined optimal rewiring as rewiring to distal cell without a link. And he demonstrated that the optimal rewiring groups in single stent KBI strategy can lead to reduce incomplete stent apposition at the side branch ostium. The result is also substantiated by the optimum trial conducted by Dr. Onuma and Dr. Miyazaki. And then I demonstrated that the side branch ostial area dilated with optimal rewiring was preserved at the follow-up in European Heart Journal 2018. However, the study was a retrospective and single center study, and the study number was very small. Left main cases was only 20. So I sought to investigate the relationship between optimal rewiring and the side branch ostial area again in another study. Here you can see our methods. Patient with single crossover stenting with kissing balloon inflation who had accessible OCT images at the post-procedure and the 9-month follow-up were extracted from the 3D OCT bifurcation registry. The registry is a multi-center Japanese registry that had PCIs for bifurcation lesions in OCT guidance. Optimal rewiring was defined as a distal rewiring without a link on the carina. The side branch osteal area were measured by the dedicated software made by Medis Corporation, Q-Angio OCT. This software can accurately measure an suboptimal side branch osteal area from the main vessel OCT pruvac, like this. And the difference in change and the change ratio of the side branch osteal area were calculated as below formula. I will share the results. 168 bifurcation lesions were enrolled in the 3D OCT bifurcation registry. 75 bifurcation lesions were selected single stent KBI strategy and had the follow-up OCT data. Left main was 35, non-left main was 40. In the patient and lesion characteristics, there was no significant difference between optimal and suboptimal rewiring groups, regardless of left main and non-left main, except for stent size. This is main result. The serial changes of the side branch osteal area of each site and condition. The red line and the blue line indicate a decrease and increase. As you can see, in suboptimal groups, the side branch osteal area was significantly decreasing. On the other hand, in the optimal rewiring groups, the side branch osteal area was preserved at the follow-up, regardless of left main and non-left main. Similar to previous reports, the side branch incomplete stent apposition was proportionally higher than that in the suboptimal rewiring group in both. In left main, the side branch osteal area in the suboptimal group at the post-procedure significantly bigger than that in the optimal group, like this. This represents a distribution of the difference in the absolute change of side branch osteal area in left main. Here is a box plot depicting the change ratio of the side branch osteal area in left main. There was a significant difference between optimal and suboptimal groups in either. While in non-left main, there was no statistically significant difference in either. So the side branch osteal area in left main with suboptimal rewiring might tend to be smaller than that in non-left main. Here, I'd like to show you representative cases in left main with suboptimal rewiring. As you can see, compartments made by residual stent strut at the side branch ostium were filled in at the follow-up, like this. There was no significant difference in clinical outcomes because the event number was small and there was a bias of only patients who was able to have the follow-up OCT image. Conclusion, the side branch osteal area dilated with the optimal rewiring position in the bifurcation lesions with single crossover stenting and kissing balloon inflation was preserved at the 9-month follow-up, regardless of left main and non-left main. Thank you for your attention.
Okay, so, thank you very much for your excellent presentation. Anyone have?
I have a comment, maybe regarding our Korean colleagues. So there is a cultural difference between Japan and Korea about the kissing in the left main. So, and I know that the trial is beginning in Korea, kissing versus no kissing. And I remember the times that with Thierry we did kissing is useful, but we have to do a good kissing. So to be to be a good kissing, do we have to enter the distal cell? For me, this will be the best use of intravascular imaging. So maybe you have a comment of Bon-Kwon Koo on this. Part of your trial is to enter the side branch through the most distal cell and to remove the connector, if possible. We need a trial because it's too long time to wait for an answer.
Yeah, so I don't want to talk in detail about the trial because he's going to present next session. So, but one thing I'd like to comment about this results is that even it is guided by OCT, there should be the optimal and suboptimal wiring. So that's the reason why when we do OCT guided and whatever guidance we made, the outcome may not good as better as we anticipated. So that I think it gives us a very important insight that if we cannot guarantee the very optimal wiring, the outcome will not be improved even with the OCT guidance or the additional procedure. So that's my take-home message from this result. But congratulations on your successful study.
Maybe Yoshi, Murasato, or Yutaka, a comment about that? The Japanese point of view?
Excuse me. Can you hear me?
Yeah, we hear you.
Good morning, everyone.
Yeah, please, you can comment about what we are discussing. There is a trial beginning in Korea. So are you waiting that we'll see a difference if we enter distally towards the side branch or not?
Yeah. So thank you for your comment, Professor Koo. So final kissing balloon inflation is considered as no advantage, at least in ESC guideline. But I think it is difficult to. I think it is very challenging to demonstrate the use of 3D OCT in clinical events because there are many factors of clinical event for bifurcation lesion. So plaque distribution and plaque characterization, and more. But one thing I can say from the study, the optimal rewiring can lead to good side branch expansion and maintain the side branch oxygen. But if you can achieve the optimal rewiring, the KBI could be optimized. However,
we need the clinical validation. You said that the clinical follow-up was the same. So what we need to invest in a 3D OCT to enter the most distal cell, we need absolutely clinical results, clinical validation. Petr?
Yeah. But if you can not achieve the optimal rewiring, I think it is one option not to dilate the side branch. So now we conduct the next 3D OCT bifurcation registry with more than 600 patients in OCT guidance for 3 years follow-up. So I will research about that. So relationship between a clinical event in the future.
So we'll see next year or not? Petr, one small comment.
Yeah, thank you, Yves. I think that the role of imaging is really increasing and it will continue. But at the same time, it's not so easy, and I am not talking about the expenses of these technologies. But I think that we have also quite good stent enhancement technologies that could be used. And I haven't seen any data from the trials that have been published yet about it can be stent boost, it can be clear stent technology, because it can get quite nice data. And I think that
this is for this afternoon, Petr. We'll speak about that this afternoon. Thank you.
Thank you.
Thank you. So the last presented by Jolanta.
So now it's my great pleasure to introduce Dr. Arun Tarai, who will be sharing with us his presentation about the stepwise provisional versus systematic culotte for stenting for true coronary bifurcation lesions, the 5 years follow-up.
Okay, good morning, and thank you very much for the opportunity to present at EBC 2023. My presentation is going to be on the 5-year follow-up of the EBC2 trial, which we first discussed at EuroPCR earlier this year. This trial was on stepwise provisional versus systematic culotte for the treatment of true non-left main bifurcation lesions. Present these results on behalf of all of the EBC2 investigators. Just to acknowledge that funding was provided for this trial from both Terumo Europe and Pi Medical Imaging. So the optimal treatment of true non-left main bifurcation disease, whether this be from an upfront two-stent strategy or by a provisional strategy, has been widely debated for many years. Early randomized trials were performed, and these actually tended to show neutral or even poorer outcomes with two-stent strategies, driven by both myocardial infarction and mortality. There was some criticism of these studies in that they involved the implantation of first-generation stents in patients with small caliber side branches, which may not have always been functionally significant. EBC2 was designed by the European Bifurcation Club in specific to address some of these concerns, and a provisional strategy which involved routine kissing balloon inflation and a T-stent if required was compared to an upfront culotte. Second generation Nabori biolumis drug-eluting stents were used, and the side branch diameter to qualify for entry had to be at least 2.5 millimeters, with a side branch lesion length of over 5 millimeters. In all, 200 patients were recruited in Europe. Monitoring of the trial was performed by CIRC, and there was an independent clinical events committee. Now, the patients ended up being relatively high risk for coronary artery disease. There was a high prevalence of diabetes, previous MI, and previous PCI, and a third enrolled with ACS lesions. The predominant bifurcation site was in the LAD diagonal, and this is where the bulk of these results apply to. You can see that the main vessel and side branch lesion length were well matched between the two groups. There was a high rate of successful kissing balloon inflation, and of note, despite randomization, there was an increased rate of bystander PCI in the culotte arm. Procedural success was defined as a main vessel stenosis of less than 30% and TIMI3 flow in the side branch, and this was high in both groups. So the 12-month outcomes were reported in 2016, and the primary outcome was MACE, which was a composite of all-cause mortality, all myocardial infarction, and target vessel revasc, and this was not significantly different between the groups. What was noteworthy was that there was only a 16% use of side branch stenting in the provisional cohort, which meant that overall this group had shorter procedures, less radiation, and cheaper procedures. So 5-year follow-up was completed in 197 of the 200 patients. The primary endpoint which we report is the same. Bifurcation-related MACE was also analyzed, and we made this composite endpoint a combination of procedural acute vessel closure, stent thrombosis, target lesion MI, or target lesion revasc. So these were the results at 5 years, and as you can see, there was no significant difference between the provisional and the culotte groups at this time period, with a MACE rate of 18.4% versus 23.7%, and it was clear that both the curves tracked a similar gradient with time. Now, this particular pattern was seen with the individual components of the primary endpoint as well. It is noteworthy that there seemed to be a disadvantage for culotte in terms of MI, and this was purely driven by peri-procedural events, which you can see at the very start of that curve. Now, the mechanism of this is unclear. Acute procedural vessel closure was very low in both groups. Culotte does involve several additional steps. Obviously, you need to pass a second stent, you need to do repeat pot distal rewiring and repeat kissing balloon inflation. It's possible that this extra instrumentation increases the chance of periprocedural myocardial injury. But we should also remember that the Kalot group did have a higher incidence of bystander PCI, and this may have contributed to some of those periprocedural events. We also looked at the influence of side branch disease length on the primary outcome, and there was no significant interaction seen. Once again, you can notice that for shorter side branch disease lengths, there seemed to be a benefit for provisional. Once again, this was driven by reduced periprocedural myocardial events, and as I mentioned, this is not of clear significance. Looking at specifically bifurcation-related events, overall there was no difference between the two groups. What was noteworthy was that the event rate was very low. It was at 6.5% in 5 years, and I think this was reassuring that we do achieve quite good outcomes in the longer term now with current bifurcation techniques and modern-day devices. You can also see the site of bifurcation failure, and this was spread in both the groups similarly between both the main vessel and the side branch. So the conclusion from this study was that the use of routine Kalot did not really improve the 5-year MACE beyond provisional stenting in non-left main true bifurcation lesions, and in particular this did not interact with the length of side branch disease. Only 16% of provisional patients required a side branch stent, which meant that over 80% of patients in this group avoided the need for positioning of a second stent, repeat pot, repeat distal wiring, and repeat kissing balloon inflation. And this clearly had a benefit in terms of time, cost, radiation, and potentially myocardial injury as well. So in conclusion, we do recommend that the provisional strategy continue to be the default approach for bifurcation disease outside of the left main. This study was published in Eurointervention, and this was the QR code for access. Thank you.
Thank you very much for presenting this reassuring data. So maybe I will just start with a comment. Do you think that 5 years after the study was performed, we would do something differently in any further, techniques used with the knowledge and so on?
Yes, yeah, I think that's a very good point. I mean, both procedurally and medication-wise, things have changed. Procedurally, there's increased use, I think, of intravascular imaging. There's increased use of lesion preparation. Things like shockwave have come out. Medications have changed over this time. We've got more potent dual antiplatelet therapies. We've got more significant lipid control agencies. And one thing that I didn't mention was the bifurcation-specific rates were much lower than the trial MACE rates, which meant that most of the recurrent events were outside of the bifurcation. So potentially, if we improve our medical control on these patients, we will reduce events further. In specific with Kalot, there have been discussions about using a DK Kalot, minimizing the area of overlap, and these changes may have also affected the outcome. I think the fact that at 5 years, the bifurcation-specific events, that they were so close, you would probably need a very large trial to then determine whether those features have an outcome effect.
And could you comment on the techniques itself? So were the operators really experts in the techniques they used, or the patients were randomized and they, like, per chance, the operators performed the technique for which the patient was randomized? But what was the percentage of port also, like final port in the Kalot technique? Do you have the data on that?
So actually, unfortunately, that wasn't recorded, but I'd say that the enrollment of this trial was in Europe, where provisional and Kalot is well known by most operators, and therefore most of the operators that took part in this trial probably had a specific interest in this. I think that any bifurcation trial, we are prone to some recruitment bias, where if the operator feels that if they're going to be randomized to provisional, they do not want to do a provisional, that is going to be a problem. So we need to understand that the patients that were involved in this trial were ones where the operators would have been happy to do whatever they were randomized to. And for every bifurcation trial, I think it's important to keep that in mind.
Do you plan to have a 10 years follow-up?
Not that I'm aware of, unfortunately.
Because we will, I think, looking at the result, we can put this trial, the results, in the series of Nordic 1, BBC 1, and this has something to see with the concept of Bon-Kwon Koo, which is we were probably treated aggressively or not, vessels which are not important. That's maybe an explanation of the absence of the, the sub-diagonal with LED sub-diagonal bifurcation has to be treated with a crossover stenting, that's all.
Yes, sir.
And we may be surprised if you look at 10 years. Remember Nordic and BBC1, you may have 5 years more, you may have a difference in mortality, what we observed in this trial. So this is another reason to be very simple in such a majority of bifurcation lesions.
Yes, and I think that goes along with what David was saying yesterday as well, that all of the stents we implant have an ongoing perpetual MACE rate associated with them. And what's not obvious at 1 year and 5 years may then be obvious at 10 years. So even talking about some of the balloon-related bifurcation studies with drug-coated balloons, it's probably important to do extended follow-up on them.
So I see now some additional question and comments. So we'll start with Kalaivani, please.
Thanks, Jolanta. I just have one comment or question or combination of both. Did you have an analysis of the bifurcations by the complexity of the bifurcation itself? So if you look at the definition criteria that studied complex bifurcations, which is slightly different, of course, and this is all-comers, so we all agree that a provisional strategy is completely appropriate in all-comer bifurcations, but the caveat on that was that in definition, they found that if there was a very complex bifurcation, so one with a severe side branch stenosis, longer than 10 millimeters of disease, significant calcification or thrombus and angulation, then sometimes a two-stent strategy in just that group was beneficial. So did you have any analysis by the complexity of the bifurcation at all?
Yes, there's not enough information gathered to look at the specific definition criteria. What I will say is that the obvious comparison is with the DK Crush trials for these studies, and that the DK Crush side branch lesion lengths on a mean were always significantly greater than what was recruited in EBC 2. And we'll talk a little bit about this when we talk about EBC main a bit later today, but the trial populations are very different, and I don't think you can apply the results to any patient group. You need to be aware of that factor, and like I said, the fact that the patients that were included in this trial were the ones that the operators would have been happy to do either strategy for, and that may not have been the case if they were faced with one of the DK Crush population patients.
Sure.
So what percentage of your patients had kissing balloon or side branch inflation? So do you know that data, or was it just left alone?
So the kissing balloon inflation was routinely performed after the provisional strategy, so it was part of the trial protocol. Yeah.
So we are late.